Okay, great. Thank you so much. And I wanted to just start out by saying thank you for inviting me. I am Janet Hamilton with the Council of State and Territorial Epidemiologists, or CSTE, and I really wanted to start out by just saying that I am really energized by your passion and determination as a group, and I'm really humbled to be talking before all of you today. Many of you come here for different reasons, but you are all here because at your core you want to contribute to the health of our world and the people that pass through it. Thank you for being people with these ideals. CSTE is both an organization of member states and territories, as well as functions as the professional society and the professional home for applied public health epidemiologists, or those epidemiologists that work in governmental public health. And CSTE members work across the disciplines of epidemiology in acute, chronic, and emerging infections. Our organizational vision is to use the power of epidemiology to improve the public's health. It is really tremendous to be standing here at this moment in our national history. The events of the past couple of years have moved my thinking really beyond to the larger framework of how the power of epidemiology can really be further harnessed to improve population health. And the issues are really big, daunting, and tough. Consider what we have seen. Emerging infections have a great level of fear. Emergencies can be transformative to how we practice epidemiology. Data, electronic health data, is stored now and available for decision making in ways that it never was before. The building of adequate health systems capacity, like surveillance and informatics, are infinitely important, and we have a shared responsibility and resiliency. Epidemiology and public health surveillance is about using data to give those that cannot speak or in most need a voice. She did tell me to point to the back, and I'm still... So I wanted to just start with this definition of public health surveillance. I think the word surveillance sometimes seems a little scary to people, and this is a classic definition. It's the ongoing systematic collection, analysis, and interpretation of health data essential to the planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of these data to those who need to know. And another way to look at it is that public health surveillance seeks data in a systematic way to make data-driven decisions and improve the health for all, a touchstone of steadiness. So let's break it apart then into these 5 big components. And first, I want to highlight this aspect that it is a continuous process. It's ongoing. It's systematic collection of data. It's doing something multiple times. Doing something once is not surveillance. It's continuous analysis and then interpretation of that data, and then disseminating the information, not just the data itself, but the information and knowledge learned after analysis and interpretation. And finally, it's then linking that data to public health practice and linkages to improve care. Good surveillance leads to good care. One way to think about public health surveillance is it's like the weather. It's continuously gathering information, making the information accessible to everyone where it can be used to make informed decisions. And you can't just do the weather one day and then be done. Monitoring the weather never ends. It's continuous, and the most up-to-date information is the most useful. It's systematic. You need a repeatable process so that the problem is counted in similar ways across all locations. Like the weather, we use the same scale so that when someone says it's 100 degrees outside, for example, we all know what that means because we're all counting things in the same way. Surveillance information is used to bring about change. Surveillance data is used to understand and define a health problem, and health problems must be well defined before they can be solved. What do we do in public health that's really different? We take the entire population. Public health isn't about a single physician practice, but it's about the entire population. And no one else does this. Clinical care only addresses the health of those seeking care at that individual facility, and it doesn't address the differences that may and do exist between facilities and practices. I've listed here some of the really key things that public health surveillance does. So we assess the full magnitude of the health problem. Public health surveillance is used to further understand the natural history of a disease. How does it start? Why are only some people impacted? From learning about the disease itself, the data can be used to inform clinical practice. I remember, as an epidemiologist working at the Florida Department of Health during the Zika response, that the first information we had was to collect blood specimens. But through our public health surveillance efforts for this emerging condition, we actually found that urine, not blood, was the better specimen, and we could detect the virus much more effectively and for a longer period of time. 3 and 4 then are about determining the distribution and spread and identifying populations at risk. Where is the disease and condition? Why are some people more likely to get infected and then develop the disease or condition? And how can we help those most at risk? Public health surveillance is also classically used to detect clusters or outbreaks or pockets of unusual frequency, and then to use the data to identify effective interventions, and also specifically which ones are the best interventions, which ones are the most effective, and how can they be more effective, and how can we populate those interventions across our healthcare system. Public health surveillance led us to understand that things like deficiencies in iodine led to goiter, or that leading causes of cancer were completely controllable exposures, tobacco. Unfortunately, public health surveillance is challenging, and the strategies are best based on the characteristics of the disease or condition. And I've actually listed, oops, now I'm going in the wrong direction, listed some of those specifically here. So some diseases have very pronounced clinical presentations, like measles has a very distinctive rash. Some diseases and conditions, or things like lead poisoning, and the developmental effects of lead poisoning take years to understand and assess because the clinical presentation is prolonged. And what are the diagnostics like for an individual disease or condition? Are there really good tests that can be done where once you have the result, it's really clear that those results are always associated with that illness? Are the tests readily available, and are they ordered on a regular basis by clinicians? And how does an individual's care-seeking tendencies play a role in how the condition is actually identified, and then how we can actually monitor it? The key is to get your surveillance system to collect the right data in order to answer the needed questions. So, Dr. McDonald is going to talk in more detail about certain kinds of data and statistics, but I wanted to talk about these 2 major ways that we quantify information, and that's in terms of incidence and prevalence. So incidence is about the number of new cases in a given population over a given period of time, and that can be critically important in determining initial diagnostic resources. And then prevalence is about the total number of people living in that same population with with the illness or condition. And prevalence, I would say, is especially important for diseases of chronic nature where people can be living with the illness for many years. If only new cases were counted, it wouldn't reflect the entire burden on the population or provide appropriate resource planning. For C. diff, of course, incidence becomes especially important because to track repeat infections or those locations or facilities with higher rates of developing new cases could be indicative of infection control problems at that individual facility. Okay, so nationally notifiable. And Christian talked some about this at the beginning, and I wanted to talk about this specific designation, which is one tool that we have within public health. There is a specific list of nationally notifiable conditions, and CSTE actually was formed in the 1950s by the then director of CDC to be the organization that gathers consensus from states and works in partnership with CDC then to determine which diseases and conditions should actually be nationally notifiable. So that's the actual charge of our original organization when we were first formed. The main function of the designation of nationally notifiable condition is that it really codifies the process of notification of case data to CDC. It's a voluntary process, and additionally, the designation of nationally notifiable recommends that states make changes to how state laws should be structured. It does not require it, but it does come with that specific recommendation from a policy perspective. And I'm going to talk actually in the next session about how state rules and regulations work with this nationally notifiable designation. The other really key thing is that designating as something nationally notifiable also provides guidance to CDC on how state data should be shared. So this is data that's collected at the state level, and then with this designation and this policy, or specifically it's called a position statement, there's specific criteria within it that talks about how the data should and shouldn't be shared. It is not the only mechanism for which surveillance is done, but it certainly is a tool that can aid in sharing and collecting of data. What it doesn't do, though, and I think is a common misperception, is that it does not come with any additional funding to support the activity. Public health as a whole is vastly under-resourced, and states do not have the same level of funding. So it does not directly support the level of effort for which cases are identified or investigated. And I talked about one of the reasons to put something under public health surveillance was to help inform clinical practice, and some people have this designation or this concept that if something is nationally notifiable, then it leads to maybe specific training programs that get implemented in physician training programs when they're getting degrees or something along those lines, and it does not do that. So it does not come with sort of a package of additional training activities. For example, in your medical schools. But public health surveillance is used very effectively then to gather information and inform that clinical practice. I feel like I'm not even touching it. Okay. So then I also wanted to talk to you now about the process for how something becomes nationally notifiable. So it's a consensus gathering process in states and among the states. It takes collaboration and time. It is a process that requires multiple stakeholder input and close coordination with CDC. It's actually an active and current CSTE member that leads or sponsors the position statement. And the position statement itself is a structured document. It has a defined template And the template itself then has multiple parts. So the template talks about the goals of surveillance, the methods, so for example, is it electronic formats, the types of data sources that should be used, and it specifies how cases should be ascertained or identified. I've mentioned, of course, that it talks about how the data should be shared, because collecting data simply for the purpose of collecting it is really a disservice. And the other really key piece of making something nationally notifiable is that it comes with agreement on a standardized case definition. And essentially that's assurance that the data across all these individual states and locations is getting counted in the same way. So for example, if you have a positive laboratory test for C. diff with no symptoms, or maybe you have someone with symptoms and in their clinical record there's a diagnosis of C. diff, but there's no laboratory result. Are those still both cases, and should they be counted in the same way? And so that's kind of the concept of the standardized case definition. And then there's a vote amongst all 50 states and the territories to essentially first say we agree on this standardized surveillance case definition, and then second is a vote to actually determine whether or not something should or should not be nationally notifiable. Currently, CSTE does have a position statement on C. diff, and it really recommends data collection and utilization of NHSN, and Dr. McDonald is really going to focus on that. And I'd be more than happy to share that individual position statement with you. In addition, that position statement also does recommend that states look for opportunities to modify their own state laws and regulations in order to make C. diff reportable. And I'm going to talk some more about state laws during the next session. So I'm going to turn it over to Cliff.
Thank you, Janet. With everything she said, my job is much easier, and I wanted to talk about what we do have in place right now in terms of surveillance and what we're trying to do to make C. diff count and really down, right, to lower this number. It's not just to count it, but it is to make it count, and we have come a long way, and I'll show you that first. We are making progress, and I spoke last year here and showed some of that progress. I just want to show the 2017 data too. Here, this is the system NHSN, and I'll talk more about that, what its purposes are. It uses a measure called the standardized infection ratio, a ratio of observed number of cases over the predicted cases. We'll talk about why that's used. So in 2017, though, now we have a 20% decline from 2015, and that's atop what were previous declines, as you can see, and it looks like right now we're on target to meet the National HAI Action Plan goal for hospital C. diff reduction and the SIR by 30%. We'll meet or exceed that, and so that is great news. And I just want to say that one of the things that I'm very involved with now is helping to get this data up in a more user-friendly way. We have a patient safety atlas, AR patient safety atlas, antibiotic resistance and patient safety atlas. And this is a place where you can go see the 2017 HAI progress report, that number for 2017, but it also has data on antibiotic resistance. It has data on antibiotic use, and I'll come back to that later. But this shows you can look in here by state at the state's performance, and then also by different types of facilities. There's 3 types of facilities where we have CMS mandated reporting. The acute care hospitals, which is what we talk about mostly, but also long-term acute care hospitals and inpatient rehab facilities. We have another surveillance system, and I'll say more about it a little bit later. It's called the Emerging Infections Program. This we call a Sentinel System, but it's population-based, covering all settings. And it has a category of healthcare-associated CDI, which really is inpatient healthcare associated. And this just shows you crude rates in that system. where you do see this market decline again. And I've shown here the percent declines. So I'm going back and forth between systems, but in the NHSN data, I've already mentioned the 20% decline in the acute care hospitals. There's a 23% decline in what are called long-term acute care hospitals. And then inpatient rehab facilities, also a 20% decline. So this is the good news, which you should always start with, right? And this progress wouldn't be possible without partners and just for the years of tremendous work done by this organization on behalf of patients. We at CDC say thank you. Thank you for inviting us. Thank you for being our partners. And thank you for working with us towards these ends. I've been working in C. diff a long time, since 2003, really. And we didn't really have any of this before 10 years ago. And anyway, that's good. And let's talk about these systems then. And some of this I said last year, but some of you weren't here, so I just want to go over these systems again. The National Healthcare Safety Network, it is a web-based reporting system used by over 17,000 U.S. healthcare facilities. For CDI, this is the number of facilities that are reporting into it. We do have over 2,500 nursing homes now reporting into it, but that's still only about 17% of all nursing homes. There's a lot of nursing homes. It is it's increasingly electronic data entry, and some of the most advanced data capture, one form known as the clinical document architecture, a way of packaging data from electronic health records. This is utilizing that. And we've really been out in front in public health in utilizing some of those protocols. You already heard from Janet the very important aspect of definitions and protocols and standardization. This has been, a hallmark of this system all along. Something else we do is we do risk adjust, okay? And that's partly because of the purposes. That means the facilities, we try to account for things between different hospitals that they can't control, like if they take care of sicker patients or something like that. We try to account for that so that there's more of a level playing field in that standpoint. And that makes it more acceptable for one of its major uses, which I'll mention, which is benchmarking. And so this does allow for more meaningful interfacility comparisons, but we are aware that it might take the face off some of the cases, right? Because you don't see the people affected, and I'll come back to that issue again. But it does. These are some of the evolving purposes of NHSN, very important for the CMS mandates of pay for performance and quality, paying for quality, and probably has been very instrumental in making healthcare facilities really wake up and take notice. But I do also want, so these data are from the CMS mandated data from acute care hospitals, long-term acute care hospitals, and inpatient rehab facilities. Those are reported by facility name and address on the Hospital Compare website. Now, you can go on the Hospital Compare website, you can pull down a couple of facilities, or you can do a comparison of a couple of facilities. But you may not realize that there's more that you could probably do with that data, and I just want to mention that. One thing is we've actually printed out, and I'll give these to Christian, all the states' observed cases of hospital onset CDI in 2017. It's 80,000 cases. So you could then see in a given state the number of people affected in the hospital. Now, these are just the hospital onset, and I'll talk more about how that is probably only 1 in 5 of total cases. But we're moving in that direction towards putting more of a face on this. And value-based purchasing, I've already mentioned that, plays an important role. And finally, as Janet alluded to, NHSN more and more facilitates state reporting mandates. There's 31 states and District of Columbia and Denver have some CDI state reporting. We have a draft document, which I also leave with Christian, and a couple of copies of it. It's some recent work from Jeremy Goodman in our policy office. where he's gone through all the states and tried to find out what they have. And there's also the CSTE has a tool, and you can get some sense too. And they're not totally different years. The CSTE document is from 17, and the draft document from our group is as of April, but it's still in draft. But you can look at it. It has websites also on there, so you can find out what are the specific reporting requirements for a given state. And NHSN is playing a big role in facilitating that. The other big system is the Emerging Infections program, and this has been very important for really understanding the epidemiology. This is 10 sites, so it's not in every state. A couple of these sites, a few of these sites are statewide, others are municipalities. This is what we call population-based surveillance, and so it involves boots on the ground. It's very intensive and rather expensive per case of surveillance. But you get a lot of detail that you can't get any other way. Actually, people going to the medical records sometimes, if they're only paper records, and looking at the records and filling out forms and whatnot, getting all the cases from that population catchment, whatever that defined is, getting all the labs engaged and all that from all different settings. And that's where we get this sense of really what the epidemiology is in the United States in terms of where these cases occur. Whoops. Whoops, I guess it's back here. Whoops, oh no. Okay, there we go. It is what we call a Sentinel System because not all U.S. states, not all the country. So we're using these 10 to project to the country sometimes, but more importantly, understanding really where C. diff occurs. Of course, we have a fragmented healthcare delivery system, and so all these different systems don't talk to each other, but this tries to overcome that. And I've mentioned already the importance of having surveillance officers on site. And these are some of the purposes, and I think you get to really see some of the data and you'll understand its purposes even more. Well, the surveillance definitions for C. difficile have not been simple because, again, our healthcare system is not simple. We deliver healthcare across a lot of different settings. Okay, and I won't go into great detail, but in the center of this is something called HCFO that really is equivalent to what is hospital onset CDI, and that is what is the main measure in the NHSN SIR. That's what we're trying to reduce in the SIR. But there's these other cases that occur after discharge. You can see out 12 weeks after discharge from a healthcare facility. We call those healthcare facility associated. And then there's these others that are the patient has not been in the hospital or in any healthcare facility overnight for at least 12 weeks. Those are community associated. And the EIP really goes into great depth into all these categories and tells us what these cases are. In the first 3 days of hospitalization, someone develops C. diff. It's going to be a community onset case, even though it was diagnosed in the hospital, they're hospitalized. But it takes usually a surveillance officer going and looking at the chart and figuring out whether they were in a healthcare facility recently to categorize them appropriately. And from this EIP surveillance, okay, we now understand this. We understand that these cases, you divide up the whole pie, you see that they're occurring in a lot of different places. And where they have their onset, or within 3 days of onset, is the first important aspect. You can see 18% of the whole, I always call it the enchilada, 18% of the whole enchilada after lunch is hospital onset. So it's only 1 in 5. So we are making progress in these hospital onset cases, but we're really making progress across that whole right side. So that half, all the healthcare associated, we're seeing progress. I can't show you the data, but there's progress in nursing home onset. There may be less progress in the community onset with recent inpatient exposures. The community associated, though, is, you'll see in a moment, really pretty flat. Now, here's how it changed. I don't know if you can see on the right upper corner, that was 2011. you can see, if maybe it doesn't show, but the hospital onset portion came from 24% down to 18%, and the other post-discharge has reduced also. And so, we're seeing progress in the healthcare associated and the community associated really isn't budging. So the epidemiology is changing that way. This shows it. Again, the blue line I already showed you, the healthcare associated CDI, that's inpatient healthcare associated, has been coming down. The red line, community association, looks like it's going up, and it may be, but I'll say more about that. This, again, remember, community associated means that they have not been in a healthcare facility for at least 12 weeks. So anyway, it looks like it's going up, but I want to mention to you, and this is something else we know from our EIP surveillance and from other data, that the way C. diff is being diagnosed has changed dramatically over the last 7 years as well. Much more increasing use of molecular diagnostic tests. These are about, on average, twice as sensitive. So just from that alone, a stable or increasing rate may, in fact, really mean stable or even decreasing CDI overall, morbidity and mortality overall. So the long and short of it is we really, and you'll hear more about this later this year when we come out with a more intensive analysis of some of these data, but the community associated may be really level during this time. What looks like increased level if the testing had been the same over all this time. And if you look at another source of data, and that's death certificates, it is good news that there are this decline in deaths where C. difficile is showing up on death certificates. And that really started to turn around right around 2008-9, right when we started to have all this reporting and a spotlight put upon it. So going back, I'll say more about NHSN. Well, what does it find? I've talked about the hospital onset disease. That's the main metric in the SIR, but we actually, in NHSN, are capturing a lot of community onset disease that gets admitted to the hospital. Because in an NHSN, the people responsible for surveillance at a healthcare facility are reporting all the cases that get diagnosed in the first 3 days as well. Those are community onset cases to that hospital, at least. Heretofore, we haven't really been reporting that. Now, that doesn't show you here, but I see some things didn't show. But this is from 2015. This shows a different enchilada. This is the enchilada of all cases reported in NHSN. 333,000 cases reported in 2015 in NHSN. The hospital onset is the blue, that's 32%, and all the others are community associated. Well, what do we do with those cases? Well, they're used actually for the risk adjustment, because we know that if a hospital is around a lot of other hospitals or has a lot of other things going on around it, they may have more C. diff coming in the front door, and we know that that has been a factor in some hospitals having higher rates. And so the question is, what can we do more with this community associated, community onset disease that's getting reported into NHSN, not for hospital benchmarking, but for helping state health departments and others control community onset disease. So this is another way to look at some of this, and I see this kind of didn't translate well. The hospital onset is supposed to be within that lighter blue onset, and all those are the cases reported in NHSN, I've mentioned. And then these other circles will show you from EIP data where some of these other types of cases who are hospitalized are coming from. This is just on average across EIP. It says that 48% of the community onset cases being reported into NHSN are probably hospitalized community-associated cases, at least on average, and then those others there as well. And how representative are those hospitalized cases of all the cases? That shows it here. Hospitalized cases are a minority of community-associated cases, but they are the sickest ones, right? If someone is dying with C. difficile, they're going to get admitted to the hospital too. So this is what we can understand about additional things we could do. So again, I mentioned to you how by state you can look at that hospital compare data, see the number of hospital onset cases reported in NHSN. Overall, that's about 1 in 5 cases. And you could just roughly say, well, 5 times that many cases are probably how many cases we have in this state, give or take. It is a give or take. It's a very guesstimate, but overall. And then if we would start reporting all the community onset cases and the hospital onset cases from NHSN, maybe at a state level, we would be putting a face, if you will, on 1 of every 2 CDI cases. And so how could that be used? I don't know. I mean, a lot of this is about, does it help to have a face on these cases when you're talking to people? And I think it does. And make people who are, and it could be healthcare systems, policymakers, others, so they can see that in their own backyard, here are their cases. And you could even get down into even a section of a state if you wanted to go on hospital compare, and you could get all the zip codes or something like that. We could talk about that. But what are we going to be doing in 2019 at the CDC? Stay tuned. Later this year, we will be publishing an EIP trends analysis. Basically, this is like the LESA paper that was from 2015, published 2015 on 2011 data. That's where the 453,000 cases came from. We're going to be giving an updated entire estimate of cases, and we're going to look at the trends, and we're going to even try to account for the changes in diagnostic testing so we can see how we've been doing. Along with that, well, not along with that, but also around the same time, we're going to be publishing the 2019 AR threat report. That will have an estimate just of the hospitalized cases, which I've been sort of talking about, and we did that back in the 2013 threat report so that numbers are comparable. And we have been refocusing our prevention. We've had some high-level strategic meetings across the division, looking at special issues around C. difficile. Recently, within the last 6 months, came out with these core strategies for hospitals that are updated. We're working to improve diagnostic testing, management of asymptomatic carriers, improving environmental cleaning, advancing inpatient stewardship, and innovation to protect the microbiome. I don't have time to talk about all those things. We are redoubling our focus on outpatient stewardship. I want you aware that there is data currently available on our Patient Safety Atlas. It's not as up to date as I'd like. It's from 2015. But again, you can find by state your state's antibiotic use, and you can even see, if you can advance the slides, where your state is in outpatient antibiotic use. This is data we purchased from IQVIA, I think it's called. It used to be called IMS. It's all community pharmacy prescribing. Finally, to try to bring a face to more of these C. diff cases, we plan to publish on our AR Patient Safety Atlas or the portal. We're transitioning to a more advanced site. By state, the total number of hospitalized CDI cases reported in NHSN. That, what I talked to you about, maybe being 1 in 2 cases of all cases. And we're going to continue to work towards the development of other innovative strategies to produce data for action that leverages prevention of community-associated CDI. It's not easy, again, because of the fragmented healthcare delivery system. I'll just say I don't think the hospitals would bear asking them to go to every record of community onset cases, try to find in their records anywhere they've been in a healthcare facility anyway. We know that that probably will not work. Maybe there's some other innovations we can do short of that or in between that. But that is all I have to say. But happy to, yeah. Thank you. That's not all I have to say. I just want to mention this. Ohio, 2006, 11th hour mandate from the governor, make CDI reportable overnight, sort of. It was a very, And it didn't come with any resources. We heard that, okay? And in this case, they did a yeoman's job. Over 14,000 cases reported. Shows you here. There really was no NHSN yet. It cost them a lot. And the reality is, I mean, we did learn. I'm not saying we didn't learn something, because back in '06, we were still learning a lot about the epidemiology. And we were standing up NHSN. We were making decisions about that. But there's probably easier ways we could have learned some of those things too, more focused. The reality is there wasn't any prevention going on. So, I mean, if you, and there's a very, early on in the surveillance of HAIs in the 1970s, it was found that hospitals with the lowest rates of HAIs did multiple things. They did surveillance, but they also did prevention. And you've got to have that right combination. If you just make surveillance a national pastime, that's what you'll have. So you have to combine it with prevention. So in this case, the only lesson is just that coordination with public health, getting input of public health as we make these decisions, and resourcing things appropriately to meet goals. I think that's the lesson. And then also, finally, to thank all these people who helped put these things together. So thank you for listening.
I will always have a question. So thank you both.
There I am. So this was actually super cool. This is kind of a lot of what we want, what I think we were sort of fretting about and interested in knowing. So not to put you on the spot, but to put you on the spot. So recently, this new treatment, this new emerging infection, Candida auris, which is all over the New York Times over the weekend, infuriating patient advocates all over the country, and probably internationally, given London's horrible job. So that is the most recent nationally notifiable infection. Why that and not C. diff?
A big reason is 150 cases compared to 400,000 cases. And the other reason it probably is action. I mean, Jen and I were talking about this back and forth in email over the weekend, and trying to think about, are there any nationally notifiable diseases that have big burdens? And STDs come up, and GC, I think, and syphilis, and these are, one thing about those is that they are actionable by public health in each case to, I think, for treatment and partner finding, case finding. In contrast, other big burden diseases like flu, influenza, of course, I don't know, 2 million maybe cases, something like that, or maybe, no, it's many more, I'm sorry, than that. But what we use, I think, pretty effectively is a lot of different systems. I don't know if you've ever looked at the flu view reports and things like this, but you'll find different systems. Sentinel surveillance, they'll have providers who see patients with influenza-type illness, and then they have so they have a combination, they triangulate around these things. I think I've tried to show you how we're trying to triangulate also. It's still a work in progress. It's just not, again, going back to the Ohio example, they did not act on any of those cases. They were just scurrying around to count numbers. So I think that's probably, Janet, do you want to say anything?
Yeah, I think your points are very well taken, and I guess I have some similar reflections, and in the next panel, I was going to talk about some of the challenges on the state's side. So I'll just bring up a few of those now also, but so I just spent 15 years in Florida, and Florida was a big state, 20 million people, and I oversaw acute communicable disease activities and the systems that supported them for those diseases and conditions that did not include the STDs, HIV, or tuberculosis, but kind of everything else. And in Florida, we have around 150 reportable diseases when I was there. And you really have to think about, when Cliff is talking about 400,000, what is it that an individual case report is something that public health can or can't do about it? And I think many times historically, when something has been made reportable and nationally notifiable as well, we are taking individual action on an individual case. And you need resources to do that. So for, take measles, for example, right? There are specific public health actions that occur. So we find the individual, we isolate the individual to prevent them from infecting others, we identify their contacts, we issue them prophylactic treatment. Public health is that net around. And I think when you have really high burden diseases, it becomes very challenging. And so to maybe expand on the thought of influenza is not reportable. 36,000 deaths every year on estimate. And we have a great prevention tool, which is vaccine, but we don't have the individual resources to follow up on every one of those individuals. It's just not there from a public health perspective, and find their contacts and issue them prophylactic treatment, which would be getting a vaccine, hopefully, to prevent them from becoming ill. So it does become a resource issue to some degree. I think with electronic medical records, we have opportunities to do surveillance in new ways. So we have very historically used Sentinel-based systems, and I think there was some discussion around EIP. So that was individual locations around the country where then they were looking at, in their sphere, the entire population. So it's not the population of the U.S., but the entire sort of healthcare plus community population, and using that to make estimates, because it was an affordable way for us to do that kind of thing. With advances and electronic data and medical records, I think there are opportunities for us to consider doing business in a new and different way, and how we want to do that and how we can tackle that together.
Can I just ask, I understand the burden that you're talking about for national reporting, but I think one of the things that patients express concerns about are why, or how you define an outbreak in a facility, and when that happens, why there isn't something posted, so that if you're a patient who, has elective surgery or who has a choice about going into that hospital or facility, can decline or delay that.
Well, in fact, that was a big part of that New York Times piece too on CORIS as well. I think almost, and Janet, you can correct me if I'm wrong, but I think almost every state has some kind of reg about outbreaks in healthcare facilities being reported to public health, and yet the definitions of what triggers that has been always a challenge. And there's been an ongoing work between CSTE and CDC in this area of healthcare associated outbreaks and trying to define them. And we have other work going on. C. diff it can very much go in these epidemic spurts of small clusters. And so again, I think the trigger is, when can the health department act on those? What are the sizes, or what are the numbers? I mean, I guess there could be different tiers and stuff, and I think these are all being discussed about just notification and then notification and action. But I think that is an issue of itself. Sometimes, as that article was pointing out, there's that reputation that the facility is always trying to protect as well, and that becomes a challenge. And then the other side of it is that there are sometimes some things that are happening that the facility is doing what it should be doing. So I think there's been a lot of discussion around how could we increase just the communication, that there could be ongoing communication about all the time between these healthcare facilities and the state health department or the local health department. And then at least you'd have an outside interest looking in, right? Because there's always the concern that is the facility itself too concerned about its reputation costs, that it's not going to go public and that kind of thing. But if you have public health notified in the conversation, then that could at least help that. Do you want to say anything more about the work between CDC and that? I can't think of the was it
Cora.
The Cora.
Mm-hmm.
Cora.
Yeah, I think so I would just echo that outbreaks in general, whether they're facility-based or in some other location, every state has some kind of regulation indicating they should be reportable. I think sometimes in individual facilities, it can be a challenge to say, are we above our baseline, yes or no? When do we notify? So I don't want to say it's always easy to make that determination for a facility. I think there are opportunities to really improve the communication. I would also say public health spends a lot of energy trying to notify people to let them know about their risks and balancing, how to provide information in the right actionable way. So people still need procedures to occur, and you need to be able to seek care effectively, and finding the right balance so that people have the opportunity to make good informed decisions, but also not to make a decision that could adversely impact them. So for example, not seek a certain treatment or something like that. That's something that's a constant discussion within public health. And I think there is also a lot of time and energy spent, for example, notifying people once an outbreak has occurred based on your individual level of risk and exposure. And public health very much wants to continue that active conversation and look for good opportunities where we can provide people the right information and also balance how people are making decisions so that they can continue to make the very best decisions.